How about anything from cardiac or respiratory that might have been really confusing that we want to cover in depth? Oh, I gotta let you talk to me. There we go. Anything we need to take an extra close look at this week that might have been confusing? Okay, we will go ahead and dive in here. So this week we continue our look through the body systems and we are looking at respiratory and cardiac this week. So when we think about the anatomy, some of the differences between adult respiratory and pediatric respiratory, what are we seeing? With our newborns, they tend to be nose breathers. They prefer to breathe through their nose first and foremost. So we call that obligate nose breathers. They also have smaller airways and those higher respiratory rates that are normal for them. As they grow, their respiratory rate slows to that normal adult um, range and their breathing becomes more thoracic. So instead of being um, abdominal breathers, they're going to be more thoracic breathers. Their lung volumes are going to increase with capacity as they grow and develop. And it will take them 7 whole years to become those thoracic breathers like you and I, where we're actually using our rib cage to breathe rather than using our belly to breathe. We also know that their ribs tend to be more horizontal in orientation than having that angle like you and I do. And because they have those smaller airways, it's a lot easier for those sounds to kind of get transmitted throughout their chest. So even though you might be listening right over their trachea and you might be hearing those upper airway noises, you might also hear them way out in their lung fields as well. So sound transmits really easily through the chest cavity. They also have increased chest compliance. So their chest wall is very flexible that allows um, them to be at risk for airway obstructions and wear themselves out while they are breathing. So, with all of those things in mind, how do we think that affects our assessment of our pediatric patients?
How we do it.
Yeah, how we do it is definitely affected.
And you said their rates will be different, so we wouldn't be alarmed, obviously, if we see higher rates in them than we do ourselves.
Yep. What signs do they give us that they're having difficulty breathing?
They belly breathe, like they labored breathing.
We can see increased work of breathing.
Their O2 will go down also.
hmm Even before changes in vital signs, what do they show us?
Doesn't like their like clavicle or like I don't know how to explain it. It like almost like sucks in
Yes.
as they're trying to breathe.
Yep. So those are
Okay.
called retractions. So it can
Okay.
happen above and below our clavicles. It can happen in between our ribs, below our ribs. Lots of places for retractions. We also can see that nasal flaring where their nostrils are getting real big on us. Other things. When we are deprived of oxygen, what happens to our mental capabilities?
We become lethargic.
We can be lethargic. What
Altered
happens?
mental status,
Yeah, altered
just
mental
becoming
status.
confusion or just
Yep. Good job, Krista. Yes, one of the ones that we always forget about when it comes to respiratory distress is confusion. That's very common. As you're deprived of oxygen, you kind of struggle to have clarity of thought. Um, what happens to our color when we don't have enough oxygen?
Turn blue.
Cyanosis.
Yep, we turn blue, cyanosis, we can be pale. Uh, okay. How do we help alleviate some of that respiratory distress? What is one simple thing that we can do that we all do naturally to help make us breathe better?
Sit them up.
Yeah, changing our position, finding that position of comfort. Great job, guys. So which finding is going to be characteristic of RSV in infants? So transitioning into those respiratory disorders.
It's going to be the contractions and belly breathing.
Yep. We're going to see those nasal retraction, or not nasal retractions, nasal flaring and retractions. Yes. So that's going to be those increased work of breathing things that we see. Okay, so as we look at this patient, I want you to think about what condition we might be talking about and what signs and symptoms we're seeing. So mom calls into the triage line, says her baby is working to breathe but appears stable, might have a fever. Mom is asked to count the respirations and thinks it's about 50 breaths a minute. She doesn't see any nasal flaring or belly breathing. So the triage nurse tells her to undress the child, turn the shower on full hot water, close the bathroom door, and take the infant into the bathroom. She's supposed to do this right away. Make sure not to give that child anything to eat or any medication, and then call the office back in 10 minutes to see what the response is. So mom calls back promptly and says the cough is better, but still working hard to breathe, irritable and hot. So the triage nurse refers them to urgent care and says it's okay for mom to drive the baby herself. But mom panics and calls 911 instead. So EMS shows up and we've got a 10-year-old or 10-month-old infant in moderate respiratory distress. Our heart rate is 164. Our respers are 42. Blood pressure is 100/70. Our oxygen is 94%. We have a barking cough, but good lung aeration. They tried to put the baby on a nasal cannula and baby pulled it off. So they did blow by oxygen and now they're on the way to the ER. So what condition do we think that we have here?
Asthma?
Not asthma. Which one has our barking cough?
Like whooping cough?
Yes, whooping cough or croup. That's going to be our barking cough as that classic symptom. What else do we see with this baby?
High heart rate and respirations. Well, respirations
Respiratory.
are kind of normal, so.
Yeah. Yep. For an infant, respirations are normal. Heart rate's a little on the high side, nothing too crazy.
Is the blood pressure kind of high?
That's okay for an infant. Baby's probably worked up and a little irritable right now. So that's going to impact that blood pressure as well. So we've got that barking cough. We've got a little bit of tachypnea, maybe, possible fever. So why did the triage nurse tell mom to turn on the shower and put the baby in the bathroom?
To allow that steam.
Yeah. Yep. So that steam is going to help loosen those secretions, relax those airways so that baby can breathe a little bit better. When we get to the hospital, what can we give to help with this increased work of breathing?
Maybe albuterol breathing treatment.
Yeah, we're going to use some corticosteroids to reduce that airway inflammation. We can usually give them orally. If it's really severe, we can do IM corticosteroids, so dexamethasone, prednisolone. What else can we give for really severe croup? What type of breathing treatment? It's going to quickly relieve that airway obstruction. Doesn't last very long, but it does provide quick relief.
Would it be albuterol nebulizer?
Nebulizer. That's what I was gonna say. A nebulizer mist.
It is a nebulizer. Do we know which medication it is? That will quickly reduce swelling.
Is it epinephrine?
Yep. Racemic epinephrine is our nebulizer treatment. So that's going to give us that quick relief of that airway obstruction. But like I said, it doesn't last very long. So we do have to watch for some rebound inflammation there. Obviously, if our child is hypoxic, we're going to give them oxygen. And anytime that we have a respiratory distress of any variety, we want to provide hydration and make sure that we keep that fever under control. In severe cases with croup, sometimes we do have to intubate these kids. So if we were exposed to smoke inhalation, what complication might we see?
Bronchospasm?
Yes, absolutely. So we could see that bronchospasm. So that smoke being inhaled irritates our airways and kind of makes them fluctuate there and spasm. So that's going to increase our respiratory distress. What instructions do we need to include for a child after a tonsillectomy? You guys got it. Avoiding that strenuous activity for 2 weeks so that we prevent any additional bleeding from that surgical site. Why do we avoid aspirin? Why don't we want to use aspirin?
Bleeding, it makes you bleed a little more.
What else are you at risk for with aspirin?
Rice
Ryan
syndrome.
disease.
Yep, Rye syndrome. So we pretty much don't give aspirin to our pediatric patients at all if we can avoid it. There are a couple cardiac disorders that we will give aspirin for, but outside of that, we try not to give it. Obviously, with any type of surgery, we have to slowly advance our diet because we've put our GI system to sleep when we went under anesthesia. And then these kids will actually prefer to sleep somewhat upright or on their side to kind of keep that blood flowing so they're not coughing and possibly straining that incision. Okay, we are doing well on time. So we are going to look at our 2 CJ Sims here. So this is Katrina. She is 8 and she is coming in for respiratory distress. So let's listen to her report here.
Katrina McAvoy came into the emergency department at 0540 with a dry cough, runny nose, sore throat, and fever for the past 3 days. Her mom has been treating her with cough medicine and acetaminophen, but states that Katrina isn't sleeping well at night and just seems miserable. She has asthma, and her mom wonders if she may have bronchitis. Her home medications have been placed in the EHR. Her COVID test was negative.
Okay. Not what I wanted. This one. So Katrina was diagnosed with asthma at 6. She did have reactive airway disease as an infant. Looks like she's got medications multivitamins, a couple different inhalers, a maintenance, and 2 options for albuterol, either inhaler or nebulizer if she has an asthma attack. So when she comes in and we look at her assessment here, what are some things that we see that are consistent with that asthma diagnosis?
The wheeze.
She's got wheezing. What doesn't match her asthma diagnosis that might tell us we've got another complication happening?
Maybe the low SP2, the O2.
Yeah, our O2 could be a result of an asthma attack. It could be something else too.
What about the pale skin?
That would be that low oxygen that we're seeing there.
The cough.
The wheezing.
Yeah, our coughing and our rhonchi, those are not going to be really consistent with asthma. Sometimes asthma patients will have a cough, trying to clear and open their airways, but really just that wheezing. We're seeing increased work of breathing kind of outside normal for her. And then in that last note, we see that she is truly having an acute asthma exacerbation. So we see her pulling herself forward in that tripod position, trying to open her chest and make it easier for her to breathe. We've got increased wheezing. So we are going to go ahead and start her on oxygen, give her a nebulizer. Okay. Yep, so she has acute asthma, and then we also have a viral upper respiratory infection that's causing the rhonchi that you're hearing, the increased coughing, struggling more so than normal for breathing. So this epinephrine we can give subcutaneously, or we could have done that racemic epinephrine in addition to albuterol to help open up those airways. And because she's having so much trouble working to breathe, we're going to go ahead and admit her and start her on IV fluids. So that's one less thing she has to worry about. We can keep her hydrated, keep her nourished with IV fluids. So we're going to take eating off the table here until her respiratory status is a little bit more stable. So when we look at her labs and her x-ray, what are some reassuring things that we see?
Her white blood cells. They're not too high.
Anything else that we're seeing that's reassuring or good news?
The Chester X-ray looks
X-rays.
clear.
Yep, her x-ray looks pretty clear overall. So those are both encouraging things to see for her. Okay, we are going to switch gears to Miss Ainsley. And she is 16. She is coming from the pulmonologist office with a fever, decreased breath sounds, a cough, and fatigue.
I stopped taking my meds and doing my chest physiotherapy. And I guess I really screwed up this time. Now I'm sick, and there will be even more medicines. I hope I get better and get back to some fun. I just want to be like the other kids my age. They had me send in my sputum a few days ago. I probably have an infection again. That's what happens when I don't take my meds.
Okay, so with Miss Ainsley, we will learn very shortly when we look at her chart that she has cystic fibrosis. So, what do you think is causing her to be in the hospital?
She stopped doing her physiotherapy for her chest.
Yep, she is non-compliant. What did you notice about her speech pattern that is very off for an adolescent? Or anybody in general? Did you notice anything about the way that she talked?
She sounded out of breath, like talking.
Yeah, she would say a couple words and then take a really long pause and then say a little bit more, really long pause. So she doesn't have a lot of stamina, really working hard to breathe there. So, like I said, she was diagnosed with cystic fibrosis at 2. She's been sporadic with medications for the last 3 months, stopped her chest physiotherapy and her meds altogether last week. So now she's coming in for a rule out pneumonia. We are doing pulmonary function tests today just to see where she's at in comparison to her baseline, and then coming up with a treatment plan for her. We saw her last a couple months ago and she was 88 pounds. Now she's 78 pounds on admission. What do we feel about that weight?
Quick drop.
Yeah, that's a huge drop in a couple months. What do we know about cystic fibrosis patients and their nutrition?
Is it high calories and proteins that they're supposed to have?
Yes. Yep. So high calorie for sure. They need 150% of normal calories just to survive and maintain. So they've got to have a really, really high intake, lots and lots of snacks to be able to meet those needs. Also, with cystic fibrosis, we have a hard time digesting fat. So we're going to rely on protein and carbs to be able to maintain that calorie count. So let's take a peek. Those are her. Okay. Take a peek at her orders here. So we have those 4 to 6 meals a day of high protein, moderate fat, moderate carbs. We also have to ensure adequate salt intake. Why do we make that recommendation? Most of the time we're saying to limit salt. Why would we encourage salt intake for this patient? Anybody know?
Can you give us a hint?
Why, if we are encouraging salt, do you think we're deficient in it?
If we're encouraging salt, then yes, we're deficient in it.
Yep. So why would we be deficient? What happens to our salt with cystic fibrosis? Where does it go?
When you sweat, you lose salt. I know that.
Yeah. So these patients lose extra salt in their sweat. So we have to supplement them with additional sodium and chloride. We're going to encourage that chest PT, our respiratory therapy, and we are setting her up with telehealth and providing that high frequency chest wall oscillating vest. So that's that big heavy vest that they put on them that literally shakes their entire chest cavity, to help loosen up those secretions so that she can cough them out on her own. We're changing up her meds a little bit. Also supplementing her diet with vitamin A, D, E, and K in a water soluble form. So normally those are fat soluble vitamins. So we're going to give it in a water soluble form because we don't digest fat very well. Again, we're going to be deficient there. We are ordering pancreatic enzymes for her with each meal or snack so that she can hopefully digest her food a little bit better. And then some antibiotics and breathing treatments to help her get over this pneumonia. With her x-ray, we see that increased fibrosis. We also see inflammation in her lungs because she hasn't been compliant with her therapies. So we are going to set up a behavioral health plan and a care contract with Ainsley and send her home with home health. What is the purpose of this?
To help her be compliant with her therapies and medications.
Yeah, we're gonna keep touching base with her frequently so that we can make sure that she is making improvements, and she is being compliant with those medication regimens and her chest physiotherapy. Unfortunately, if this pneumonia does not resolve, we may have to do a PICC line for IV antibiotics for several weeks. And if we can't get this pneumonia cleared, there's the possibility that we might have to do a lung transplant for her because of that cystic fibrosis. Unfortunately, infections for these patients can be extremely deadly. So we have to be very, very careful. We want to get her home as soon as possible so that we get her out of the hospital with all of those big, nasty germs that could make her even worse. Okay, back to our Minty here. Looking at our last respiratory condition. So here we have a 7-year-old that has a fever, is in acute respiratory distress, is agitated and restless, showing signs of air hunger. Dad laid him down on the stretcher and work of breathing, respiratory distress got way worse. So the patient sits up and assumes the position of comfort. We see that tripoding again, using accessory muscles to breathe. Our lips are blue. We have lots of retractions, nasal flaring, and we are drooling, breathing with our mouth wide open. What condition do you think we have?
RSV?
No, the drooling is the big key. We're sitting
The
up,
seizures?
drooling, respiratory disorders,
Oh, respiratory.
drooling profusely.
Is it cystic fibrosis?
This is an acute one. We're not going to be able to swallow any of our secretions. We can't cough. Starts with an E.
Exacerbation?
This is epiglottitis. So we get swelling above our vocal cords that causes severe respiratory distress. It gets much worse if we try and lay down because all of those secretions are going to pool right above those vocal cords. Like I said, we can't swallow anything. We can't cough. So really, really distressing, causes a lot of anxiety in our patients. So if you ever see a patient coming in that they are tripoding, they are in severe distress, and they are drooling profusely, they likely have epiglottitis. The most important thing to remember with epiglottitis is we never do anything that will agitate them or never put anything in their mouth until we have an advanced airway in place. So increased agitation can cause laryngospasms and we can lose their airway. So that's why we're automatically going to intubate these patients, maybe even do a tracheostomy if we have to. Would be temporary, but still a possibility for us. So we have to have that advanced airway in place before we try and look at their throat. Can't put anything in their mouth. We are going to sedate them. We're going to do that rapid sequence sedation for prior to intubation. Obviously, can't have anything by mouth because we could potentially aspirate here. They're going to be on IV fluids to keep them hydrated. They are going to prefer to be somewhat upright to make it easier for them to breathe. Okay, which is going to be an effective way for us to reduce SIDS? Yep, the best way to reduce SIDS is educating about safe sleep. So alone on their back in a crib. We don't want anything loose around them. We don't want to place them on their stomachs to sleep because there's a good possibility that their head could get face down and obstruct their airway. And we actually want to encourage the use of pacifiers. Moving on to our cardiac patients. So what do we include in their plan of care? Those cardiac patients. So all of these are important for our cardiac patients. Obviously, vital signs, making sure they're oxygenating well. Our respiratory and cardiac systems are very closely related. All patients need supportive therapies and growth and development considerations. And then we would prepare them for surgery if it is a surgical condition. So looking at these cardiac disorders, so for all of these cardiac disorders, you're going to see the normal anatomy on the left, so you can compare it with the abnormal on the right here. So we have two disorders that are the same thing, just a different location. So these are our septal defects. So a septum is just this big wall here in between the chambers of our heart. So for this particular defect, we have an atrial septal defect. So we have a hole in between the two upper chambers of our heart here. So this hole allows oxygenated blood from the left atrium to flow backwards into the right atrium. So we're going to monitor these patients for heart failure, any arrhythmias, and growth delays. Most of the time, we are either going to do surgical or catheter closure for any of these defects. So like I said, there's two septal defects, your atrial septal defect and your ventricular septal defect between the upper chambers or the lower chambers. The easy way to remember this, A points up, so we're talking about the upper chambers of the heart. For our ventricular septal defect, you can see that that hole shifts to the lower chambers of the heart. Your V points down, so we're talking about the bottom chambers of the heart. Same condition, different location. Next, we have our patent ductus arteriosus. So we have this extra vessel in our heart that you can see right here that connects our aorta and our pulmonary artery. And we need this to promote our in utero blood circulation. So because we're not using our lungs when we're in the womb, we have this extra vessel that kind of bypasses our lungs a little bit. Normally, this vessel closes on its own within a couple days after birth, but sometimes it doesn't close. So that's why it remains patent. So we get this connection between our aorta and our pulmonary artery. So that can cause deoxygenated blood to get into our systemic circulation. So this is one of the few conditions that we can treat with medication. So the medication that you need to remember for your HESI is indomethacin. So that is the medication that hopefully will close that PDA without having to surgically correct that defect. If you have worked in a NICU or shadowed in a NICU, you would know that we don't like to use indomethacin anymore because it can cause some pretty significant GI problems for especially our premature babies. So in practice, you will actually see us use ibuprofen and now Tylenol actually. But for the HESI, remember indomethacin is the medication that we use for a PDA. If that doesn't work, then we can actually do a catheter closure, and we put a little plug here in this vessel to prevent that, kind of close off that connection. If that's unsuccessful or that PDA is too large, then we can actually go in and surgically tie off that vessel. With our coarctation of our aorta, that is our kink in our garden hose. So normally we have this nice wide aorta that carries all of our blood to our body. But as you can see with this coarctation, we have this kink in our garden hose. So we get all this blood rushing, and then only a little bit makes it past that kink. So the easiest way to screen for this is doing upper and lower extremity blood pressures. Your upper extremity blood pressures are going to be really high. Your lower extremity blood pressures are going to be significantly lower because we just don't get the blood flow to the rest of our body. And the last one we're going to talk about today is tetralogy of Fallot. This is the hard one for everybody to remember because this is 4 defects all rolled into one. So we have pulmonary stenosis, we have a ventricular septal defect, we have right ventricular hypertrophy, and an overriding aorta. So all 4 of those things cause us to have significant issues with perfusion. So we are at high risk for what we call TET spells or a sudden cyanosis. So suddenly we'll be playing and active, will turn blue, our oxygen drops, we may even pass out because of it. And that's just, we have too much deoxygenated blood getting into our systemic circulation, and that's what's causing this. So for tetralogy patients, the best intervention for them is getting their knees up to their chest. So that's going to increase the pressure in their belly to push more blood into their heart, to increase the possibility of oxygenated blood making it through their system. We have to get their knees up to their chest even before we put oxygen on them. If we don't do that, they can't utilize that extra oxygen that we're giving. So with an infant, you have to do it for them. For a toddler or an older child, you might see them running and playing, carrying on, and then all of a sudden they'll stop dead in their tracks and they'll squat. They're doing the same thing that we would if we were pulling their knees up to their chest. So what is happening here is normally we come through our right atrium, we go down to our right ventricle, then we're going up through our pulmonary artery. But if you remember, I said we had pulmonary valve stenosis. So that pulmonary valve gets really, really thick and really hard to work against. We also have this VSD, this big opening in between our ventricles. So this way is really, really hard. This way is really, really easy. So we're going to prefer to go through that VSD instead. So we're bypassing our lungs here. We're not getting oxygen. So from our left ventricle, we are skipping our lungs and our oxygen and sending that blue blood out our aorta to the rest of our body. Also, I said we had right ventricular hypertrophy. So that right ventricle gets really big and beefy. It's a super muscle. So it's going to push really hard. And that makes even more of that blue blood go over to our left ventricle because it's big and beefy. It's really strong. So it's overcompensating. So again, more blue blood getting out into our pulmonary circulation, or our systemic circulation, sorry. So those are the reasons why we end up with these TET spells. There is a lovely video in your lecture that actually walks through a drop of blood and these TET spells. So if you're still confused by that, that's a really good place to look. Okay, just a couple more questions here. Looking at some of those other cardiac defects that are not anatomical issues. So our child has been diagnosed with rheumatic fever after a recent strep throat illness. Which medication should we expect to administer? You guys got it. Penicillin. How long are we on penicillin? Does anybody remember?
10 days.
Way longer.
14.
We are on penicillin for 5 years. So we're treating that initial strep throat infection, and then we're going to continue that penicillin to make sure there is no way that strep throat infection can come back. Because if we get a recurrent strep throat infection when we have rheumatic fever, we can have mitral valve damage. So we're really, really cautious with these patients, making sure that they don't get another infection when they have rheumatic fever. Even our pediatric patients can get hypertension. Which finding is going to be most suggestive of secondary hypertension? So secondary hypertension is when we have high blood pressure caused by an underlying medical condition or a medication. So our secondary hypertension is the less common version. Primary is one that develops gradually over time with an unknown cause. We can't pinpoint one specific cause for primary hypertension. So we see things like obesity, genetic causes, sedentary lifestyle, diet issues, advanced age, whereas secondary is going to be caused by some sort of underlying disease, like a kidney disease, an endocrine disorder, our coarctation of our aorta, sleep apnea. We also know medications can cause hypertension. So things like oral contraceptives, NSAIDs, corticosteroids can all cause that secondary hypertension. Okay, guys, last one. We are admitted with a fever, conjunctivitis, rash, and swollen hands and feet. What do we have? Nice work. That is our Kawasaki's disease. So we have these symptoms that happen after typically a viral illness. These patients will have a really high fever. They'll go in and seek treatment because they're just not getting any better. And they still continue for an extended period with this high fever. And now we're getting these new symptoms along with it. Okay, that's going to wrap up our respiratory and cardiac lectures here. This week, you guys have your CJ Sim, your first one that is due. So make sure you get that in by Sunday. Remember the screenshot with your name, patient's name, the date you completed the assignment, and your score. For next week, we have our second CJ Sim that's due and our discussion 5 post. Remember, initial post has to be in by Wednesday. Your peer responses have to be in by Sunday. You will notice I turned on homework grades this week. So you see how your homework is impacting your overall grade. So for some of you, it is helping, but for others, it is hurting you. So if you did not turn in your week 5 NCLEX questions, or you got a note from me saying there was an issue with your week 5 NCLEX questions, you have until Sunday to get those in for partial credit. And that will help your homework grade. These CJ Sims are going to be crucial to your homework grade. So they're 10% of your homework. So make sure that you get those CJ Sims in on time. Next week, we have quiz number 4 that is going to go over our cardiac and respiratory information that we had in class today. Does anybody have any questions over anything coming up?